Hi everyone, welcome to my YouTube channel. Let us begin with a new topic today, which is head injury, a part of general surgery. To begin with, let us discuss the classification of head injuries. Based upon the clinical findings, head injuries may be of two types, which is open head injury and closed head injury. So, what do you mean exactly by open? Open injuries are those wherein there is communication between the internal and the external environment of the body. Okay? So, inside the cranium, the brain is well protected by the presence of dura mater and cerebrospinal fluid. So, when there is tear in the dura mater and leakage of CSF through the nose, that is known as CSF rhinorrhea, it is known as open type of head injury because there is communication between the internal cranial environment and the external environment through a body cavity. Coming to the closed type of head injury, there is no signs of CSF leakage. Moving further, based upon the type of injury, injury may be Coop type. Coop type means injury occurs at the site of blow. Contra Coop means injury occurs opposite to the side of blow, which means if the patient is hit on the left side, then the injury will be on the right side. This is site, okay? Next is missile injury. Missile injury means the injury which is brought about by a fast moving object, for instance, a bullet that pierces the tissue. It leads to open injury because there is again communication between the internal and external environment. Moving further, there is blunt type of injury. Blunt type of injury means there is no sharp trauma, laceration, or excessive tissue damage. These can be an example of acceleration injuries and deceleration injuries. It is very important. Acceleration injuries is the injury in which the brain is stationary and the object is moving. For example, if you take into consideration a road traffic accident. For example, if you take into consideration that a man is standing and he is hit by some fast moving object like a cricket ball or something. Deceleration injuries are those in which the brain is moving. That is, for example, road traffic accident. The man is under acceleration and the object which he hits, for example, if the person hits a truck or a pole, the pole is stationary and the person is moving, so the brain is moving in this case. Coming to post-traumatic changes in brain, what changes occur after the brain injury? It may be of two types: primary lesion, secondary lesion. Primary lesion is those that occur at the time of the trauma. Secondary lesions occur due to after effects of trauma. So, primary lesion में सबसे पहले we have diffuse neuronal damage. It is associated with blunt injury. It is delayed in onset, more than 14 hours or last for a week. Next is cerebral concussion. Cerebral concussion is associated with non-penetrating injury. Penetrating injury is associated with lacerations. Non-penetrating is associated with concussion. There is altered consciousness, confusion, amnesia. Amnesia means you tend to forget the things. These are of two types amnesia also, anterograde and retrograde amnesia. In concussion, there is no structural damage. This is a very important point. There is no structural damage. Then there is limb spasticity, which means rigidity or stiffness of the limbs, that is the hands and legs. Okay, moving further, it is contusion. Contusion includes bruising and edema. Contusion is visible with the naked eye. It is seen at the gyri that get injured against the bone. So when the brain is moving inside the cranial cavity, it gets hit to the bone And then there is inflammation like bruising, edema of the brain gyri due to injury by hitting against the cranium. In this case, pia mater, the innermost lining is torn. So this is very dangerous, and blood flows into the subarachnoid space. If you aspirate the CSF in this case, you will get a blood tinged aspirate. Moving further, common sets of contusion include the tip of the frontal and the temporal lobe. This is lobe, not love. This is lobe, temporal lobe. Superior and anterior cerebellum, anterior brainstem. Okay. Then comes laceration. Laceration means deep cuts. Okay, for example, if you look at stab injuries or slash injuries, especially slash injuries, जहाँ पे the person is slashed or cut with a sharp instrument like a knife or something, then that is called laceration. Okay, lacerations are deep cuts that lead to profuse bleeding. Profuse bleeding is there. Now, how do you treat this laceration? You have to palpate it with gloved finger, rule out fracture. How do you rule out fracture? You palpate and check for step deformity. Step deformity you have to check for. If there is no step deformity, it means there is no fracture. If there is a step deformity, then you have to reduce the fracture first. There are various instruments which are used to reduce the skull fractures. We will talk about that when we discuss this topic in oral surgery. Now we are just looking at the general surgical aspect. Moving further, we have to rule out the fracture. Then we have to treat the laceration. So for treating the laceration, suppose say this is the laceration. Laceration is associated with multiple ragged edges, which is known as skin tags. So you have to trim that skin tags. Before that, you have to ensure that the hair that is there in this region, it is either shaved off, or if shaving is not possible, it is managed with the help of some soap solution or something like that, so that hair does not fall into your operative field. After that, we administer local anesthesia, that is 1% lignocaine to the patient intradermally. Then we trim the skin tags. Trimming helps to get very smooth and refined edges that can be easily approximated and heal with minimal scarring. Then we have to apply artery forceps to the galea. Now what is galea? Scalp has 5 layers, right? S, C, A, L and P. So S for its skin, C for its cutaneous tissue, A is for aponeurosis. This aponeurosis layer is also known as galea aponeurotica. So why this is necessary? Because galea is considered a layer below which if hematoma is present or if fluid is present, it can further damage the brain tissue. So management of the galea is important. The galea should always be intact. So if the galea is damaged anyways, you have to place in sutures. Further, at the end, you close this scalp laceration with the help of interrupted sutures. Now, types of injuries. Abrasion. Abrasion means breach in epithelium. So, this is the skin. This is the connective tissue. This is the epidermis. This is the dermis. Okay, the part of the epithelium that forms the retipex and all, it is considered as dermis. Dermis is further divided into two parts, reticular dermis and papillary dermis. Then underneath it lies the connective tissue. सबसे ऊपर वाली layer, it is the epithelium. So abrasion में the injury lies only to the level of epithelium here. Like minor scratches and all, you call it abrasion. Next is laceration. Laceration means a breach in epithelium and connective tissue. It is like this, extending full thickness. So this is known as laceration. Next, there is contusion. Contusion means the overlying skin is intact, but there is bleed below the skin. Okay, so it may not be visible as a frank bleed. Frank bleed matlab kya hai? A wound is there and blood is oozing out of that. No, that is not seen in contusion. Instead, there is pooling of blood or collection of blood below the skin. So the skin may appear swollen, it may appear bluish in color. So that's contusion. Then there is degloving injury. Degloving injury means, for instance, this below the CT, if there is muscle or bone or nerve, then there is separation of this CT and epithelium from the underlying tissue. A gap is created here between CT and the underlying tissue. Degloving injury is a very dangerous form of injury. It can lead to something known as compartment syndrome. So what happens in compartment syndrome is that there is separation of epithelium and connective tissue from the underlying structure, and again there is a lot of pressure, and if the pressure is not relieved, there may be complete necrosis of this whole region. So in compartment syndrome, what we have to do is we have to give a straight incision so as to relieve the pressure formed due to this area of separation. Moving further. Now comes the secondary lesions. As I told you, secondary lesions are those that are caused after as a result of trauma, but they are very delayed. They're the result of primary lesions. Secondary lesions, they are caused by decreased oxygen, decreased systolic blood pressure, increased intracranial pressure, increased cerebral perfusion pressure. Now, secondary lesions include brain swelling. Brain swelling mein there is cerebral edema, venous congestion. Then there is intracranial hemorrhage. It is a very important topic we shall be discussing further. It is classified into extradural, subdural. It causes brain compression. See, this is the cranial cavity. Now, the cranial cavity is a very rigid closed structure. The space inside the cranial cavity is always the same. It cannot be changed. Suppose this is the brain and there is a hematoma here. So if there is blood here, it will grow and it will tend to put pressure on this brain. Due to the pressure on this brain, there will be again neuronal damage, there will be confusion, there will be various other manifestations that are specific and different for extradural and subdural hemorrhage. So it just causes, broadly speaking, it just causes brain compression and increased intracranial pressure. The pressure inside the cranial cavity increases. Okay. Then secondary lesions also includes infections. In open head injury, it is obvious because there is contact with the external environment, particularly through the nose. There is CSF rhinorrhea, so bacteria can enter. Then it can cause meningitis, empyema, and in case of closed head injury, as I said, that there is a hematoma, it produces pressure. It may appear as a swelling, which may be confused in some cases as a tumor. So it is known as Pott's puffy tumor. But it is differentiated from a tumor because there is a history of trauma and there is a sudden appearance of the swelling, not very long standing. So that helps to differentiate it from the tumor. So history taking is very important in this case. Next comes ischemia. Ischemia is the lack of oxygen. Then there is hematoma. Hematoma is the pooling of blood that is spilled from a blood vessel. Then there is conning or herniation through the tentorial hiatus or foramen magnum. Conning or herniation means if you look at the base of the skull, there is a cavity known as the foramen magnum through which the spinal cord exits. When there is further exit of brain content that should actually be into the cranial cavity, but it is leaving the cranial cavity through this foramen magnum. It is known as herniation. Okay, then there is epilepsy. So moving further, let us talk about a sign, that is the Victor-Horsley sign. Victor-Horsley sign means there is increased body temperature on the paralyzed side due to cerebral compression. Now moving to the generalized treatment of head injury. So like any other trauma, head injury is also treated by the ABCD management. According to the recent ATLS guidelines, there is another C added here, which is the small c. So it is now C, A, B, C, D, E. So what do you mean by CABCD guidelines? सबसे पहले जो small c, it is standing for control of laceration and emergencies, which means if there is a major bleed, for example, if the femoral artery is bleeding or some abdominal aorta is bleeding, so it is a major bleed which can lead to life-threatening complications. So first you have to control the major bleed. Then you have to check for airway and spinal support, which means the patient's airways should be very clear. Airway, how do you check for airway? You ask the patient his name. If the patient is able to speak properly, then we assume that the airway is normal. The airway is not compromised. There is no obstruction. If there is an obstruction, there is a difference in voice and the patient may not be able to speak in severe cases. Then we move to breathing. Breathing should be non-sternus, matlab it should be without any effort. Breathing should be in a normal rate. There should be no hyperactive movements of the chest. The movements of the chest should be symmetrical. The breath sounds should be normal. All this we will talk about when we talk in the chapter trauma. Then we will learn this in detail. Then next comes circulation. Circulation and hemorrhage control means if there is any fluid loss, for instance, if there is any blood loss, then you have to manage that by giving extra IV fluids and all. And apart from that, if there is any other anomaly, you may have to give the CPR. This all comes under the topic circulation. Next is disability and neurological evaluation. This is done once the patient is normal, he is stabilized, he is conscious. Then you go on for the disability and neurological evaluation, where you check the reflexes for each nerve specifically and also test if the patient is able to move his arms, his legs properly based upon the findings that you see in CT or MRI. If the patient has head injury, then the evaluation is different. For some other injury, the evaluation is different. Next comes exposure and environmental control. You have to expose the entire body of the patient and you have to check whether there is something you missed out during the early management. So what is the admission criteria of a patient in head injury? If there is history of loss of consciousness, then you have to compulsorily admit the patient for observation. Then if there is a temporal fracture, okay, so temporal fracture is commonly associated with the fracture of the middle meningeal artery, which is again responsible for EDH, which may manifest a bit late. So in that cases also you have to admit the patient. Then there is history of seizures and GCS less than 8. GCS less than 8 means you have to go for tracheostomy, so obviously the patient will be admitted. Care of the unconscious patient, you have to take care of the patient's feeding, which is done by the Ryle's tube. Urine passage done by urinary catheter. It is also required for monitoring of the urinary output. Apart from that, there is eye padding. So as we discussed earlier, airway treatment, it includes cricothyrotomy, tracheostomy, drug assisted intubation. Breathing में bilateral chest movements you have to check for. Then you have to palpate the trachea. The trachea should not be deviated to one side. If it is deviated, then you have to suspect pneumothorax or hydrothorax. Then circulation, you have to maintain the systolic blood pressure over 90. Then you have to check for GCS. Again, moving to the types of injury, as we discussed, there is laceration, there is skull fracture, there is major trauma, minor trauma. Skull fractures के types here we will be discussing later. Now, talking about intracranial pressure. So intracranial pressure, the normal value of intracranial pressure, that is the pressure inside the cranial cavity, is 8 to 12 mm of Hg. If the intracranial pressure is more than 20, then there is severe pressure on the underlying brain tissue. It will lead to cerebral perfusion, which is the blood flow to the brain. It will be decreased due to swelling. There will be pressure on capillaries. They will not be able to deliver the blood properly. So there will be decreased cerebral perfusion. There will be brain swelling and injury. Cerebral perfusion pressure, it means mean arterial pressure minus the ICP. This is an important formula if you can remember. Treatment of intracranial pressure defects. Okay. First you have to do head elevation, hyperventilation, sedative, muscle relaxant, diuretics. Most important diuretic that is used in cases of head injury is the mannitol. It is an osmotic diuretic. So it works by osmosis. Mannitol infusion is very essential when there is brain edema or increased ICP. Next, we give thiopenton sodium. We help the patient perform thermoregulation. Then we proceed with seizure control. Effects of increased ICP include coma, infections, vessel damage, and nerve damage. Then there is something known as Monro-Kelly doctrine. It means sum of the volume of brain plus CSF plus intracranial blood is constant. Then there is a note which is not relevant to the theoretical point of view but very relevant when you go on for history taking of the head injury patients. Always note if there is dilated pupils. Then you have to note for behavior changes like irritation, confusion, trouble in walking, drainage of fluid from ear or nose, it may be CSF. There is history of vomiting if the patient gives history of seizure or numbness in one of the arms. If there is in both arms, then it may be due to shock or something. But if the patient specifically gives of history of numbness or weakness in one arm, then you have to be suspicious for the head injury. Investigations may we do the normal blood profile, which is the CBC. Then we go for serum electrolytes, then ABG, then this और pulse oximeter से हम लोग सब measure कर लेते हैं. Then CT and MRI, which is very important in cases of head injury. So next is secondary damage mechanism. How does trauma affect the brain? So this is the etiopathogenesis. For example, traumatic brain injury, if trauma occurs, then there is decreased cerebral blood flow, decreased cerebral perfusion, increased intracranial pressure. Then there is failure of cellular pump because the cell is not able to get proper oxygen. Then there is failure at the cellular level. So there is increased calcium and sodium intracellularly, excitatory amino acids. Then there is cell destruction and cell death, hypoxia, most common. Then there is free radical formation and proteolysis. Then coming to the signs and symptoms of traumatic brain injury. It includes, for mild injury, there is loss of consciousness, confusion, headache, dizziness, vomiting, nausea, and insomnia. Then for moderate injury, there is loss of consciousness, slurred speech. Slurred speech again points towards the motor neuronal defect. Then there is limb weakness, again injury to motor neuron. Lack of coordination, persistent headache. In case of child, you can observe eating and crying, altered behavior while feeding, and extreme crying. Now comes the topic Pott's puffy tumor. Pott's Puffy tumor. So what is Pott's puffy tumor? It is a subperiosteal infection caused by osteomyelitis of skull. Osteomyelitis, what is osteomyelitis? It is the inflammation of the medullary cavity of the bone that starts from, for example, this is the bone, okay, this is the medullary cavity, this is the periosteum. So in osteomyelitis, the inflammation starts from the medullary cavity and then gradually progresses to involve the periosteum. It is characterized by generalized features of any infection, for example, pain, there is increased thirst, there is pain, there is foul odor, there may be discharge. Okay, so most common site is the frontal bone. Source of the infection is the frontal sinus or suppurative otitis media, which is the middle ear infection. Now, what is the clinical feature? It is the formation of a dumbbell-shaped swelling. Dumbbell-shaped abscess, boggy frontal swelling, scalp tenderness and pitting edema. Means if you press it, there will be a pit formation. It will not rebound and reach the original level. Investigation of choice is CT. Then treatment includes burr hole drainage, aspiration of pus and prescribing suitable antibiotic. Now comes an important thing, which is CSF rhinorrhea. Rhinorrhea means moving excess things moving out of the nasal cavity. So CSF rhinorrhea means there is communication between the intracranial cavity and the external environment through the nose. That is, there is tear of the dura and there is leakage of CSF through the nose. There is communication between the intradural cavity and the nose through a dural tear. Common types include traumatic and non-traumatic. Confirmatory signs, there is two things. First is ring sign. This part is very important from your entrance point of view. So it is a PYQ. So firstly, we will see what is ring sign. Ring sign or halo sign. This is also known as halo sign. So what happens in halo sign is that there is a clot which appears like a halo with one layer of blood and surrounded by a layer of clear fluid. So it appears like a ring or halo. This is an important sign which you see when there is CSF mixed with any secretion from the nose. Then there is reservoir sign, means in certain position there is a more release of fluid. That is, for example, if the patient is sitting upright, there is more release of fluid, or if the patient is supine, there is more release of fluid. Another thing which is seen in lab investigation is that beta transferrin. It is an important marker that helps you to identify the CSF. This is a PYQ from NEET 2022. So please keep this in mind. Now moving to intracranial hemorrhage. Intracranial hemorrhage is again inside the cranial cavity it is occurring, and it may be intraparenchymal or intraventricular. It is characterized by rapid progressive headache, neural deficit, and based upon the site specific sign and symptoms, if it affects it is in the cerebral cortex, it is leading to hemiparesis, which means paralysis of half side of the body. If it is in pons, it will lead to cranial nerve deficit. If it is in cerebellum, it will lead to ataxia and vertigo. Diagnosis, it is done by CT scan, PET, MRI and X-ray. So before we discuss the type of skull fractures, I would want all of you to study the base of skull first. We will discuss the base of skull anatomy first. So base of skull anatomy, base of skull is divided into three different portions. It is the anterior cranial cavity, this is the middle cranial cavity, and this is the posterior cranial cavity. What is important is that what structures are present in what cranial cavity. Starting from the posterior one, posterior cranial cavity has the hypoglossal canal through which the hypoglossal nerves and vessels pass. So cranial nerve 12. Then there is the jugular foramen through which past cranial nerve 9, 10, 11. Then coming to the foramen ovale. What passes through this is MALE, which is the mandibular nerve. Most important one here is the mandibular nerve, which is the part of fifth cranial nerve. Then there is foramen spinosum, through which passes the seventh cranial nerve. There is the superior orbital fissure, and also there will be optic foramen somewhere here. So from this passes the third cranial nerve, fourth cranial nerve, sixth cranial nerve, optic second cranial nerve passes. So this is very important. You have to keep this in mind so as to understand the types of skull fractures and the clinical manifestation seen in each type of skull fractures. So if you are clear with this, we shall proceed further. So skull fractures. Skull fractures may be divided as linear or simple fracture, which is due to severe injury. It may lacerate the middle meningeal artery and cause the extradural hemorrhage. Okay. Then there is depressed fracture. Depressed fracture means the depression is more than the inner table of the skull seen in CT. Its complications include dural tear, pneumocranium, intracranial hemorrhage, infection, and increased intracranial tension. What do you mean by depressed fracture? This is the skull. The second segment, it is below the inner table. This is the inner table. So the fracture segment moves below the inner table. This is also known as Pond's fracture. Coming to these three are very important, not only from the university exam point of view, but also from the NEET MDS point of view. Anterior fossa fracture signs and symptoms. It includes CSF rhinorrhea because of fracture of the cribriform plate. So again, the CSF released, it will have glucose, it will have transferrin beta. Then comes the subconjunctival hemorrhage. Okay, there will be hemorrhage on the conjunctiva, red color eye. So this is seen. Then there is next feature is raccoon eye. Raccoon eye means surrounding the eye there will be bluish black discoloration surrounding the eye. This is the eye. There will be bluish blackish discoloration similar to the one that you see on a boxer's face after he gets punched. So this is known as raccoon eye. Then there is involvement of which cranial nerves? So anterior cranial cavity, it contains superior orbital fissure and optic canal. So there will be involvement of cranial nerves 2, 3, 4 and 5. Next, there will be dilated pupil because pupil is again supplied by cranial nerve 3. Also, anterior cranial cavity, some fibers of the olfactory nerve can be damaged, so there will be partial anosmia as well. Next, moving to the middle cranial fossa fracture. It includes epistaxis again, that is bleeding through the nose. Then it includes otorrhea. Otorrhea means CSF escapes through the ear cavity. It is associated with temporal bone fracture, very important. Middle cranial fossa contains two foramen, namely foramen spinosum, foramen ovale. Apart from that, it also contains the internal acoustic meatus. So again, the ear nerve, that is the vestibulocochlear nerve, is involved in this case because the presence of foramen spinosum. Then cranial nerve 7 or the facial nerve is involved, and because of the moving further, posterior cranial fossa, it causes a boggy swelling in neck. because there may be herniation of the brain content, so it will appear as the swelling in neck. Apart from that, there is battle sign. Battle sign means this is the mastoid, this is the patient's ear, this here somewhere it is the mastoid process. So there is bluish discoloration, that is bruising of mastoid process. This is known as battle sign. It is a very important clinical sign. You have to always remember, never forget battle sign, or you will lose an important battle in your life. Moving further, cranial nerves which are involved. So in posterior cranial cavity, there is hypoglossal nerve. So there will be involvement of cranial nerve number 12. And apart from that, there is jugular foramen. Jugular foramen. So there will be involvement of cranial nerve 9, 10, 11. Brain hemorrhage. Brain hemorrhage may you don't need to learn about infratentorial hemorrhage as such. We will directly move to the hematomas. Hematomas are very important. So first hematoma is the extradural hematoma, as the name suggests. If this is the cranial cavity, this is the bone. Again, this is the pericranium. This is the dura. Then there is a hematoma here. So it is extradural. This is the dura. This is the brain. So extradural hematoma में there is a hematoma formation or collection or pooling of blood outside the dura mater. So coming to the clinical features and what and how happens, it is the commonest type of hematoma you can ever see in a head injury, associated with temporal bone fracture, occurs due to laceration of middle meningeal artery. This is very important. It is also a PYQ. So, extradural hematoma occurs due to the laceration of middle meningeal artery associated with temporal bone fracture, due to which there is pooling of blood and collection of it outside the dura mater. It is also associated with history of lucid interval. Lucid interval, it is very important. Lucid interval, what happens in lucid interval is that there is trauma due to which patient loses its consciousness. After 1 or 2 hours, sometimes the patient gains the consciousness. He appears very normal. He talks to you. He may go to the washroom. And then he loses his conscious again. Secondary loss of consciousness is due to brain swelling, compression, etc. Then there is decreased GCS. There is presence of Hutchinson's pupil. Okay. So Hutchinson's pupil, what is Hutchinson's pupil? Means that initially there is pupillary constriction. Then there is dilatation. Then there is bilateral dilatation. So this is known as Hutchinson's pupil. This is important. Then there is tachycardia earlier, then on later stages there is bradycardia. Also an important thing seen in this is Kinney-Stokes ventilation, which means repeated cycles of hyperpnea, then hypopnea, then apnea. First there is hyperpnea, means fast rapid breathing, more excessive than normal. Then there is hypopnea, which means slower breathing. In between the two there is apnea, which means zero breathing. Investigation is urgent CT scan, then it is followed by surgical management, that is the clot decompression with open craniotomy. How does this appear on an X-ray? So it appears biconvex in shape. As you can see, this is the EDH. It appears biconvex like a lens. So this is biconvex appearance on CT scan. Okay. Then surgical management. For surgical management, you have to give a vertical incision on the zygomatic process. This is the zygomatic process. You have to give vertical incision 3 centimeter above. Then strip the pericranium. Then you have to drill a hole with the burr, Hudson's brace. Then you have to evaluate the blood clot, which appears like blackcurrant jelly. Then you have to extend the hole, and you have to control the bleed from the source, which is the middle meningeal artery, by bipolar diathermy. Bipolar diathermy means it is a form of coagulation instrument. You use heat to coagulate and stop bleeding. Then you have to apply sutures to prevent the stripping of the dura mater. So there is a mnemonic for all the features of this extradural hemorrhage. So the mnemonic you see here, it will be an interesting one. So it is, let me be your cozy X. X say we have the extradural hematoma. ठीक है. Now L say you have the lucid interval. M say you have the marching paralysis. Means paralysis starts from one point and then proceeds to involve the whole body gradually. So it is known as marching paralysis. Then B say you have biconvex appearance on the CT scan. Then there is C. C say you have Kine-Stokes ventilation and commonest type of fracture. Okay, so these mnemonic you may use to remember all the features of EDH. Moving further, there is a difference between extradural hemorrhage and subdural hemorrhage. Subdural hemorrhage occurs below the dura mater. Okay, so EDH is seen in young patients. It is a very important table. Please try to remember as much as you can. Vessel involved is middle meningeal artery. Here the vessel involved is the subdural vein or bridging vein. Onset, it is very early. It is early to late. Lucid interval is present. Hutchinson pupil is present. Marching paralysis is present. Here all the three are absent. In this case, the X-ray or the CT scan of EDH shows biconvex appearance, and this one shows concavo-convex appearance like a banana. Now coming to types of SDH, it may be acute or chronic. Acute one occurs in 0 to 3 days. It is hyperdense with respect to brain. What do you mean by hyperdense? So in CT scan there are two terms, hyperdense and hypodense. Hypodense means it appears less black in color. Hyperdense is it appears more blackish in color. Hypodense appears less blackish in color. Then SDH में there is more cells, less water. Then it occurs by tearing of a bridging vessel. Coming to chronic SDH, again it occurs in the period of 21 days due to rupture of a bridging vessel. It is also managed by burr hole drainage under LA. Then there is subacute SDH, which is isodense. This is D. Isodense with respect to brain. And then comes chronic one, which is hypodense with respect to brain. Coming to subarachnoid hemorrhage, it occurs due to rupture of the circle of Willis. Berry aneurysm. Circle of Willis, if you remember in anatomy, you have this circular thing that supplies the entire brain consisting of the anterior cerebral artery, posterior communicating cerebral artery, all this. So surgery is very easy if you go back to anatomy and read it. Otherwise, there is a difficult time learning it. Then there is sudden onset headache, which is known as thunderclap headache. मतलब बिजली कड़कती है तो जैसे एकदम से फट करके फटता है ना, बिजली कड़कती है, तो वैसा सा headache होता है. Then there is photophobia, which means if you look at the light, the patient gets irritated. He avoids looking at the light. Then there is vomiting. CT scan and the treatment of choice. You don't have to learn it. There is intracranial hemorrhage. It is characterized by rapidly progressing neurological deficit. Means it rapidly progresses to involve multiple nerves. Differential diagnosis is ischemic stroke and investigation of choice is non-contrast CT scan, which is NCCT. So this is a picture of SDH. As you can see, this is concave or convex in appearance. It is similar to a banana. This. I hope you enjoyed learning from today's session. If you have any doubts, you can please text it in the comment box. If you like this video, please like, share and subscribe, and I will be waiting for any feedbacks, and do let me know which topic you want to learn next. Okay, goodbye.